Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Matthew Sherrer and Brooke Vining. Matthew is an anesthesiologist. Brooke is a nurse anesthetist. Together, they wrote the KevinMD article, Care Teaming, a new paradigm for anesthesia care teams and beyond. Matthew and Brooke, welcome to the show.
Thank
Thank
you.
you for
Thanks for
having
having
us. Yeah.
So, I'm going to ask each of you briefly just to share a quick word about yourself, story, and journey. So, Matthew, why don't you go first?
I am a anesthesiologist at UAB here in Birmingham, Alabama, my hometown. Spent 11 years in private practice here in Birmingham, and then made the jump over to academics 5+ years ago, and really enjoying the ride here at UAB.
Perfect. And Brooke, you're a nurse anesthetist. Tell us a little
I
bit about your
am.
story.
I am. I'm a nurse anesthetist. I've been at UAB since 1998, so I'm in my 26th year, and really excited to be in my current position. I'm the Associate Vice President of Perioperative Services, so I'm both in the anesthesia space and then in the anesthesia adjacent spaces. And Dr. Sherrer and I partner in the anesthesia space. We're really excited to be here and talk with you all today.
All right. So let's talk about your KevinMD article, Care Teaming, a new paradigm for anesthesia care teams and beyond. So, Matthew, tell us the events that led Brooke and yourself to write this article and maybe talk about the article itself for those who didn't get a chance to read it.
Yeah, this is a real life story for us. We have actually lived this and done it here at UAB. About 5 years ago, the relationship between our anesthesiologists and CRNAs was incredibly sour. It was broken, I would say. We still call events back then our trust fracture. And we realized at that point in time that our communication, our relationship was so bad that we were likely a threat to patient safety. Our institution, being as supportive as they are, recognized that with us and actually chipped in to help make that better. They hired a skilled facilitator, a psychologist consultant to come and work with our teams. And we are now 5 years out of that. And we have really, I think, helped change the culture back to one of collaboration, one of mutual respect through our ACTOC team. What is that? That's the Anesthesia Care Team Optimization Committee. That's what we call the group that got together. Lots of amazing people in that group. Did some really hard things at the beginning and are really on the back end now doing some really cool things. But it took a lot of courage to sit and have some of those early discussions. And one of the things we talked about early in those meetings was these ideas such as care teaming being an Amy Edmondson concept, collective intelligence being an Anita Woolley concept, mutual learning being a Roger Schwartz concept. And all those things have a few kind of common threads. And that is continuing the flow of information through conversation, right? Inviting information from all parties on the team. And then empathy, right? Actually caring about your teammates, getting to know them, spend time with them outside of work, know about their family, know a lot about them so that you care about them, so that you develop that relationship and can carry that over into your workspace. A lot of work has gone into this. We kind of chose to focus on Amy Edmondson, who's kind of the titan in this world of teaming, to talk about those concepts, and then to say that in our world, we have politics, we have professional politics. Those things can spill over in our lives into our workspace. I personally think that it commonly does in healthcare. And rather than avoid that, rather than just bury our head in the sands, let's actually discuss those things. Let's actually discuss the undiscussable and see if we can use that to make us better.
Yeah, I think you nailed it. And I think that what you really hit on that I think was important at in the preliminary part of our journey was the fact that we had become purely transactional. We weren't relational. We weren't having those kind of connective touch points. We certainly weren't doing it intentionally. If it happened organically among some of our teams, it kind of happened organically, but we weren't focusing on that, and we were not fracture proof by any stretch of the imagination. I think that I know personally for myself, I didn't even realize how vulnerable we were until we had the trust fracture. With the benefit of hindsight, we had been teetering on that point for many years. And then, we did have, kind of a more frank trust fracture, but we were already there. We were right at the precipice, sort of looking over that big canyon and prepared to fall. And all it took was one push, and that's what happened.
And Brooke, during that time of tension and perhaps leading up to that trust fracture, what were some examples of some of the issues that would lead up to that from your perspective?
Right. So at the time, I wouldn't have had the words for it, but it was microaggressions. It was kind of death by a thousand cuts in the workday. Things that we had just become accustomed to tolerating, being terse, even if it's just a simple sentence in our preoperative area, or lack of communication and having an anesthesiologist walk in and say, "Oh, I wanted this set up." And the CRNA finding themselves on her heels saying, "Oh, I didn't anticipate that. Now I may look like I was not ready to provide care for the patient." And it was just this really disjointed flow throughout our day. I know now, with the benefit of hindsight, that those kinds of microaggressions have serious cumulative impact over time. They're not survivable long term. I know that for certain. And I would say it predisposed us to the vulnerabilities that I just mentioned, where we could not take a single blow and have an organic passive recovery. It required an intentional recovery with our facilitator that Dr. Sherrer mentioned.
Matthew, you mentioned that these trust fractures eventually jeopardize patient care. Now, how did that happen? What was an example of that?
Yeah, when I say our relationship was bad, I mean it was bad. Meaning like so bad that people would see an anesthesiologist, me, others coming down the hall, turn and go the other way. Not being called for induction, not being called for emergence. Just that communication that's so important to team-based anesthesia care, it was lacking. And we kind of go out and tell this story now as a cautionary tale. Please, anybody listening, don't let your team become so fractured that you are a threat to patient safety. There's none of us come to work every day and say, you know what, I'm going to be mediocre at patient care today. We all come to work wanting to be excellent. Don't let your teams get to this point, and take our story as a cautionary tale. We think that we have definitely changed our culture, more of a collaborative culture. I know that communication has improved. So please read this article and feel free to contact us. We are happy to share our journey with anyone who will listen, because it really does come down to our patients and us.
So, Brooke, tell us about that turning point that brought both of those sides together. What was that like? What led up to that? And was there like a third party that brought you guys together?
Right. Yeah. So there was sort of a presentation of sorts to introduce anesthesiology assistants. Some of the listeners may be aware. Those are practitioners who provide anesthesia care in a team-based model along with anesthesiology. And while that does exist in Alabama to some extent, there's not a large platform or a large number of AAs practicing in our state, and certainly not any training programs at UAB. And so we became aware, and by we, I mean the UAB CRNAs became aware of a presentation that Dr. Sherrer participated in that was sort of asking the questions of saying, do we have an anesthesia provider shortage? If the answer is yes, what are all of our options here? What are the opportunities to increase our provider number to care for our patients? But the translation to the CRNAs was very much a threat to our, a threat to our survival, if you will. It was introducing a competitor into our market. It was challenging us to say, are we going to have to also train the people who might potentially someday take our jobs? And so it really did happen in an overnight. The awareness around the presentation happened. And really, we went home one day somewhat loosely knitted together, of course, fraught with the microaggressions I mentioned earlier, but we came back the next day, a team fully divided. And so we all became aware of sort of the icy nature of our relationship. And that was escalated to our hospital leadership, to our vice president of clinical operations, and then to our CEO ultimately, and our CEO of the health system. And they took heed of our warning. We were self-reporting, hey, we've got an issue here. This is not going well. This is worse than it's ever been. I'm not sure how we pulled ourselves back together, because there was no one willing to sort of take the first step. And even when there was a first step, there was ill receipt of the first step, right? Like the olive branch might have kind of been tried to pass across the line. There was nobody standing there to take it. And so at that time, we escalated it, and our VP and CEO, they really listened to us. And when we looked them in the eye and said, we have patient concerns here, they listened, and they brought in a third party to come in and do mediation, facilitation, and start the kinds of conversations that we needed to get us back on the road towards teaming again.
Matthew, take us into that room where mediation happened. What was it like? What was the tenor of the conversation like, and how did you guys make progress? Despite that culture of tension, what was it like inside that room?
It was tense. I remember it well. It was divided. I distinctly recall our MD leadership team on one side, our CRNA leadership team on the other side of the table, very much divided physically across the table. But I think what our facilitator did so beautifully was this approach of, hey, in this first session, Matt, anesthesiologist, you don't get to say really anything other than what you hear your CRNAs say. So Brooke and her colleagues got to say, hey, you know what? This is what you guys have done that makes us feel unimportant, unnecessary, devalued. And this is how your actions have impacted us. And I didn't get to say, no, that's not what happened. That's not what I mean. All I got to say was, Brooke, I'm hearing you say this. That's it. And we kind of walked away. There was some harsh things said in that meeting. It was painful. And we walked away from it, I think, probably not feeling that great. However, A few weeks later, we got to do the counter of that, where the anesthesiologist got to express how they felt devalued by some of the CRNA narratives out there. And they didn't get to say anything other than, this is what we hear you say. With those things on the table, I think we were able to rebuild. I think having that facilitator was incredibly important to keep us within certain guidelines. We used the Roger Schwartz model, a mutual learning model, as a guide, and those were kind of our guardrails. So she kept us in that on the road, basically, and out of the ditch. And from there, the conversations they became much more fruitful. And we began to see what other people brought to the table, what other perspectives, what other skills. And then eventually we realized, hey, if we do this right, we are greater than the sum of our parts. Where we found ourselves was not even additive. We were inhibitory to one another. We can actually, if we do this correctly, move past additive, and we can get to synergy. We can be greater than the sum of our parts, but that's going to take work. And here we are 5 years later. Can I say we're 100% there? No, I'm not going to sit here and say that. But can I say we're certainly well farther down that road? Absolutely.
Brooke, how long did it take before you noticed some appreciable change after those initial meetings?
Yeah, that's a great question. I think about that sometimes when I'm reflecting on this journey. And I think it was probably the third session, the two sessions that Matt just explained. There was a third session where we started to try to focus on what's more alike than different. We started to ask each other, what brought you to anesthesia? Why do you do this for a living? What attracted you to the specialty? And as I started to hear the anesthesiologist say the same things that I would say when if that question were posed to me, we started to say, where are we more alike than we're different? And that really then started for me to start to really challenge myself to say, okay, I've almost chosen openly to not think that we have the same ideals, or that we didn't come to the table with the same goals, or that we don't want the same things out of our career. I had decided with, preconceived notions that they were different than the CRNAs, and the anesthesiologists had decided the same thing. And so I think that was really the turning point. I will say that was probably more of an internal awareness that started to grow in us versus an external ability to share and say, okay, this feels like common ground. But that for me was when I really started to personally feel a shift.
And Matt, was there anyone on the MD or CRNA side that couldn't bridge that gap? Were you guys unified on each side in terms of bridging this gap and making things better? Where there's just some people was a bridge too far?
Definitely, there was some people that was a bridge too far. I would say both sides faced a lot of pressure. This was a very public thing here at our institution. People knew when those meetings happened, and you better believe I had people in my ear. Hey, Matt, walk in there and tell them this. I'm sure Brooke had people in her ear. Hey, Brooke, walk in there and tell Matt this. So we had people kind of telling us, this is what you should go tell them. We do, and they do. It was tough. It was tough to bridge that gap, and I think it took courage for the leaders that were in the room. But we ultimately got to a place where we said, you know what? We don't actually decide that. The credentials committee decides that. Our training decides that, who can do what. What we want, and where I believe we're getting to, is we want a team that before they take care of a patient can discuss the patient, can discuss the care of the patient, can discuss how they want to do things, can actually acknowledge, do we have learners in the room? Hey, SRNA, do you still need numbers and experience in this? Hey, medical resident, do you still need training on this? And let's get to a point where at the head of the bed around that patient, we can all respectfully discuss how we're going to take care of that patient, best patient care we can possibly deliver, also acknowledging those people that are on the team. Let's get to a point where we can do that at the head of the bed individually, not where a guiding committee comes out and says this is what we're going to do. So yeah, we faced a lot of pressure at the beginning, and I think we're at a much better place now than where we started.
Yeah,
Matthew, is a situation like this specific to your hospital area? Like, what are you hearing from hospitals across the country, nationwide? Is this pretty common?
Yeah, so I think scope of practice is a big deal in healthcare. And I will say this, I want to get this out there. I am a member of the American Society of Anesthesiologists. I support my specialty. I'm actually the president-elect of my state society. I love the specialty of anesthesiology. It has given me an amazing life, and therefore I owe this specialty my advocacy. Brooke is a fellow of the American Association of Nurse Anesthetists, right? That's a tremendous honor. She has a wonderful career because of that specialty and should advocate for that specialty. However, politics still comes into play. And can we get to a place where we have balance in our thinking, right? Where we can acknowledge our specialty, but we can potentially say, hey, on the front lines, This is what we do. This is what we believe in. These are the values that we hold, which is an inclusive, respectful, and fulfilling workplace. And let's actually, on the front lines, do something different. Let's come together in a collaborative nature. So we are certainly by no means saying politics is bad and we should avoid that. However, we are saying on the front lines, we believe that acknowledging that tension is necessary. And then when you do that, you can actually build on that and build the best healthcare teams that we possibly can through those teaming values.
Brooke, how are things today with the relationship between the CRNAs and the MDs?
Yeah, I can say much better than they were in 2019. The progress has really just been tremendous. But Matt has mentioned it a couple of times so far is that we're not finished. There's still opportunity. I think that the opportunities are not only internal, but external, outside the walls of UAB. This was all behavior and mindsets that we had to unlearn because we'd not been taught proper teaming out of the gate. I was never taught that in nursing school or in nurse anesthesia school. Matt has shared that wasn't really taught in medical school or in his residency. So we spent these last 5 years unlearning that behavior, and really where we see the value add that we can contribute is how do we not create and continue to educate and have providers, nurses enter the healthcare environment and have to unlearn behavior? What if we taught this on the front end? What if they don't come in and create these fragilities among the teams that then impact patients? What would that look like? And so that really is where I think our team is now, is understanding the recovery that we've had, and it's been successful and it's mighty and we're proud of it. But also, what do we do with our recovery? We don't just hold on to it inside of the walls of UAB. We don't hold on to it just inside the walls of where we're currently practicing, and we don't take it to our university, for example.
So I'm going to ask both of you the same question. And Brooke, I'm going to ask you first, from your perspective as a CRNA, what kind of lessons can you share with other CRNAs so a situation like this doesn't happen? Because if left untreated or unresolved, like Matt said earlier, it could harm patient care. So Brooke, what will be your advice to other CRNAs who may be listening to you here?
Yeah. So I think as an SRNA, when I was training and early in my career, I developed an amount of tolerance for the microaggressions I mentioned earlier. And I felt like that was part of being a CRNA, that you sort of just developed that tolerance for things you may have friction throughout your day with the anesthesiologist that you're working with on any given day. And that is just part of doing the job. That's just an expected piece of practicing anesthesia in a team model. So I would really challenge that now. That should not be a piece of anyone's day, both inside and outside of anesthesia. That the toll that takes over time, again, is not survivable for any team. And we're not serving our patients well. There's no valor in biting your tongue repeatedly. Now, do we engage in constant conflict? No, but we really have to take ownership of the fact that functioning as a team is just as important as the way we take care of the patient's blood pressure or heart rate. There's a moral imperative to function at a very high level in healthcare delivery today because there is nothing happening in a silo, again, both inside and outside of anesthesiology. So that would really be my advice, is to move away from that cultural sort of acceptance of friction in your day and sort of take it more head on to say, wait, how can we have a day where neither of us leave mentally exhausted because we've had this, again, death by 1,000 cuts throughout our workday?
And Matthew, I'm going to ask you that same question. So for the anesthesiologists who may be listening to you and maybe experiencing the same situation that you guys experienced 5 years ago, what's your advice to them?
Yeah. So the day that it hit home for me, it was a year or so in, we did a survey of our ACTOC leaders, kind of anonymous, but we wrote some comments out. And one of them was, somebody said, I no longer go home and take out my frustrations from work on my family. And that to me was a gut punch. Like, number one, I can't believe that I ever contributed to that. But number two, hey, this is something that is worth doing. We should keep on down this path. That was a great motivation to continue. As we've said, I don't think this is an anesthesia exclusive problem, right? This is something that's pervasive across healthcare, other specialties, other hospitals. And the thing that I would say, the kind of mindset change that I have is that if I claim to be an evidence-based physician, if we all claim to be evidence-based healthcare clinicians, then if we concede that we certainly practice in a team environment, which healthcare is these days, healthcare is a team sport, then we also have to understand the evidence behind teamwork and what that means. And it doesn't mean one person yelling commands at other people. There are certain situations where that works. But if you take that mindset into everything you do, I believe you can actually damage the care that you provide to the patient. So that was a big shift for me. Understanding the evidence of teamwork. It's not something I learned in medical school. It's not something I learned in residency. I would argue that I was even taught an extreme version of that to the contrary. And to go unlearn that has been hard and incredibly rewarding. And it's something that Brooke and I want to continue to share with anyone who will listen.
We're talking to Matthew Sherrer and Brooke Vining. Matthew is an anesthesiologist. Brooke is a nurse anesthetist. They wrote the KevinMD article, Care Teaming, a new paradigm for anesthesia care teams and beyond. Now I'm going to ask each of you just to share some take-home messages that you want to leave with the KevinMD audience. Brooke, why don't you go first?
Right. So we reference an article from Cotter as our iceberg is melting. And I would just say, when this happened to us, not only did I not realize that my own iceberg was melting, I didn't even realize that we were on an iceberg together. And so there really is the opportunity to take a step back as clinicians in all specialties and ask yourself, what's going on with my teaming currently and what's not working? And again, it's a moral imperative to embrace what's not working in a way that you commit to change that for your patients.
And Matthew, will end with you.
Yeah, well said. To anybody who's considering, hey, look, we recognize in our teams what Matt and Brooke are talking about. We want to embark on this journey. I would tell you it's hard. That Iceberg is Melting is a great book, a great guide, a great path. We actually had that up on the screen in every meeting. Where are we on these 8 steps of Cotter? But change is hard and you're going to face resistance. I like to go back to Simon Sinek talks about the law of diffusion of innovation, that change. There's a human phenomenon where you'll have some early adopters, but you're going to have a lot of people who are in the late majority or even laggards who are going to resist. And that used to bother me. It used to bother me that people would resist a change effort that I was trying to implement, that we were trying to implement. And you kind of have to get to the point where you say, that is a social human phenomenon. It's okay. And we're going to focus on those early adopters, see if we can get that early majority and see if the wave can then spread. But there's going to be pushback and that's okay. But as Brooke said, we believe this is a moral imperative for our healthcare teams. So focus on those early adopters and, you don't completely ignore your colleagues who are laggards, but you also at the same time, don't let them drag you down in your effort.
Brooke and Matthew, thank you so much for sharing your story, perspective, and insight. And thanks again for coming on the show.
Thank you.
Thank you.